So I'm supposed to give the appetizer to this panel. So I'm going to try to set the stage here. Complex atrial fibrillation and valvular disease. And I'm going to talk about a patient that I think all of us have seen. And it's a typical presentation. We'll walk through it. And then the patient has brought questions to see what's the best next step. All right, so 75-year-old female, severe MR, new onset atrial fibrillation. I'll put an asterisk. New onset meaning this is the first time she has come to the doctor with it. Chronic kidney disease, it's about stage 3. And she's admitted with acute on chronic weakness, about 3 weeks of just acute debility. Now at baseline, she has limited functional status due to hip orthopedic issues. So she's not the most robust functional candidate. So she comes in, here's the electrocardiogram. She's in atrial fibrillation. She's left anterior fascicular block. And here is her echocardiogram. The first thing, I want to point your eyes to the left, obviously peristernal long. The left atrium is quite large. The mitral regurgitation is also significant here, and we'll get more information. Here's a 4-chamber view. Obviously, I'm showing these pictures just to show this is a posteriorly directed jet. You have a very horizontal coaptation line. You have a massive left atrium. And so everything is fitting with, this looks like atrial functional MR. The LV function, even in atrial fibrillation, looks preserved. Here's the TR jet, and mind you, this is during her index presentation where she has a right ventricular systolic pressure of around 65. So she goes, because of the initial presentation, and everyone deserves a shot at sinus, she goes for TE DCV here to understand not only what's going on with the valve, but also in prep for cardioversion. And you'll see here, there's no surprise here that the mitral regurgitation is severe, and there's no other functional sort of pathway with her mitral valve. This looks like it's all due to functional MR. And just further understanding of the valve. So these are multi-point reconstruction. You'll have seen a ton of these by the end of this weekend. But just to orient you, you have your blue plane along the mitral valve annulus here. And what we're trying to show here is, again, that this coaptation is not ventricularized. It's not a V-shaped coaptation. This is likely all due to long-standing atrial fibrillation and chronic changes from the left atrium. She had a CT chest for another reason, and I wanted to show, sometimes tomographic imaging allows us to truly get the sense of the atrial size compared to the ventricular size. And though her presentation was, and I quote, acute, you can tell that this process has been ongoing for quite some time, and perhaps her functional status and her orthopedic issues have limited her assessment of the effect her cardiac situation has had on her life. So she has a successful, quote-unquote, cardioversion, but she returns to atrial fibrillation 2 weeks later, and I don't think that's a terrible surprise. While in atrial fibrillation, she's New York Heart Association Class 3. Over the last 6 months, she's been in and out of the hospital with heart failure. But when she's in normal sinus rhythm, her MR seems to be reduced, and she says she feels better. So she comes to clinic with some questions, which I think our panel will help us decide. Will fixing my valve through surgery or a percutaneous approach help my symptoms? Or will addressing the rhythm first help my symptoms and ease my mitral regurgitation? She is not particularly interested in a procedure if she can avoid it due to her functional status. I think this is a patient we've all seen before, and which pathway to go through will hopefully resolve this question in the next 15 minutes. Thank you.